Welcome, and thank you for joining us, whether you're a current shareholder or exploring Adherium for the very first time. I'm Dawn Bitz, Chief Executive Officer of Adherium, an Australian company and global leader transforming respiratory care through connected digital health solutions. As an ASX-listed company with a global footprint, our commercial focus is squarely on the US market, where private and government payers are now reimbursing for continuous care and remote patient monitoring. That shift is transforming how chronic respiratory diseases like COPD and asthma are managed. And Adherium is right at the center of that transformation. Today, we're sharing breakthrough results from the iCARE respiratory health program conducted with Intermountain Health, one of the most respected and innovative healthcare systems in the United States. To date, iCARE has enrolled nearly 900 patients, making it the largest and most data-rich digital respiratory program of its kind. These results don't just validate our technology, they mark a turning point in how respiratory care will be delivered and reimbursed going forward. During today's presentation, we'll open the floor for a Q&A session, and you're invited to submit questions anytime using the chat function on screen. We will address these questions towards the end. This presentation includes forward-looking statements, and actual results may differ. Joining me today is Dr. J. Allen Meadows, a globally recognized and highly respected leader in respiratory medicine and healthcare economics. Dr. Meadows currently serves as the Executive Director of U.S. Advocacy and Governmental Affairs for the American College of Allergy, Asthma, and Immunology, where he also served as past president. A lifelong physician, he's treated thousands of COPD and asthma patients, and he understands firsthand the challenges that they face. Today, Dr. Meadows will outline the clinical realities of chronic respiratory disease and how critical factors like adherence and proper medication use can dramatically reduce hospitalizations and emergency visits. Both of those drive significant healthcare costs. He will then connect those insights to the iCARE program results, showing how our data directly translates into fewer exacerbations or flares, lowers costs, and improves outcomes. From there, we'll hand over to Keven Gessner, Adherium board member and senior executive advisor. Keven is a leading expert in US payer market access, and he'll explain how this clinical impact becomes payer economics. He'll also share how Adherium is already translating those results into commercial success, getting patients onto our technology through remote patient monitoring programs across the United States, clinical practices, and hospital partnerships. With that, Dr. Meadows, over to you to set the stage and frame the clinical problem that we're solving.
Well, thank you, Don. It's a pleasure to be here. Nearly 40 million Americans live with chronic respiratory disease, and for them, it's not just a diagnosis. It's a daily reality that impacts quality of life and drives billions in healthcare costs. Asthma and COPD often look similar. The inhalers we use are the same, and they cause breathlessness and coughing and wheezing. And together, these conditions represent one of the largest and most expensive challenges in healthcare. And they're exactly where digital innovation can make the biggest difference through proactive behavior modifications. Moving to the next slide. You know, when most people think about asthma or COPD, they think about somebody taking a whiff of inhaler before they exercise, and that's not who we're talking about. For many with moderate to severe asthma, this means frequent attacks, daily symptoms of coughing, wheezing, shortness of breath, visits to the emergency department that disrupt work, school, and family life. And for those with COPD, the symptoms just get steadily worse, with almost constant coughing, shortness of breath, and flares that become life-threatening and require emergency intervention. Asthma and COPD have similar symptoms, and they're driven by inflammation, although it's a different type of inflammation. And, you know, I'm struck by the fact that we as physicians in the healthcare space use a lot of big words. And so I want to explain what inflammation is to me. And so while I was preparing for this presentation, I may have picked a little bit on my cuticles and made one of them bleed. And after it quit bleeding, it kind of turned red and oozed clear stuff. And that's really what the root of inflammation is. And in asthma, it's driven by genetics, it's driven by allergens. And COPD is driven just by the damage that's already happened to the lungs, whether that be from smoking or other factors. And but there's a big clinical difference. The changes in asthma are reversible. So if we get somebody with asthma and we get them on the right medicines, often their lung function will normalize. But the story's different with COPD. These are irreversible changes. And as the inflammation continues, the lungs get more damaged, the lung function decreases. And that's really why we're going to focus a good bit now on COPD. And these patients are living with persistent breathlessness, daily coughs, and flare ups that knock them off course and send them to urgent care, the emergency department, or the hospital. And it's a tremendous burden for not just the patients, but for their families, but really bigger than that, for the healthcare system really as a whole. So moving to the next slide. In the United States, the economic burden of COPD is truly staggering, approaching $60 billion a year. And for severe patients, the cost can exceed $18,000 each annually and are exponentially greater if an ICU admission is required. And nearly half of that spend is directly tied to hospitalizations and emergency department visits. And the most expensive events and the ones we want to avoid. And if we can keep patients from reaching that point by improving adherence and preventing flare-ups, we're not just protecting their lungs and quality of life, we're also protecting billions of dollars in avoidable costs. And that's the kind of impact that matters the most to patients, providers, and payers alike. So moving to the next slide. Again, we use a lot of big words, and exacerbation is one. And I've heard it, patients exacerbating and just all kinds of variations. It's like, oh, you people, please speak English. So, I mean, the word is, it's like an attack or a flare up. That's what we're talking about. And so if I lapse into doctor speak, I apologize. I may use it, and I think it's even on our slides here. But we've just seen that nearly half of the spending of COPD comes from these hospitalizations and emergency visits. But what actually pushes patients over the edge? What makes them end up in a hospital bed? Well, for most, it's the first flare up that triggers a dangerous chain reaction. The best predictor of a future flare is a previous flare. And once that first flare happens, the inflammation accelerates, the lung function deteriorates, and it makes one flare after another more likely. And after each one, it's harder to recover. And this is where the costs start spiraling out of control. A patient experiencing 1.5 flares a year or more sees lung function decline twice as fast as those who don't, while often developing additional comorbidities. And for someone who's had 3 or more flares a year, the hospital readmission skyrockets almost 11 times higher than those without frequent flares. And this is the clinical tipping point. Preventing that first flare isn't just good medicine. It's the single most powerful lever that we have to reduce admissions and cost. Next slide. So these flares or exacerbations aren't just a lung problem, they're a whole body problem. After we see flare-ups like this, we see a spike in cardiac complications in the month that follow a flare. We think because of the stress and the inflammation that goes far beyond the lungs. And severe exacerbations are associated with an 80% higher risk of death. That's the end point of this spiral if we don't change things. And unlike asthma, it's a trajectory that doesn't self-correct. Once this cycle of flares and decline and complications begin, it just keeps accelerating. And without timely intervention, that's where our patients are going to end up. And so it's our job to break that loop early, prevent that first flare up. And when you prevent that first flare up, you stop the cascade that leads to cardiac fallout and hospitalizations, or even worse. You prevent the first flare up, you change the entire course of the disease. So moving to the next slide. So the good news is that we know how to stop that first exacerbation before it stops. Patients simply need to take their medicine correctly and as prescribed. And that's what we mean when we talk about adherence. And, in the clinic, we use the word non-compliance or non-adherence, and that's just kind of considered a bad word. But, adherence is them actually taking it, is the positive version of the word. And until recently, we really haven't had a reliable way to manage it in real life. And the evidence is clear. Once adherence reaches about 60%, the risk of hospitalization drops by roughly 50%. That's an enormous clinical and economic win. So how do we get here? Well, I'm gonna brag a little bit. I'm in a university practice now and work for the College of Allergy full time. But when I was in community-based practice full time, I was the top prescriber of these medicines in Alabama. And and not just the top prescriber, I was bigger than 2 through 10 combined. And yet, even though I was the big winner, fewer than half of my patients consistently picked up their refills. And if this is what good or great looks like in the real world, then it's pretty clear this isn't working. And, you know, even if they did pick them up, I had no way of knowing whether they were actually taking the medicine the way they prescribed. And that's two very different behaviors, going to the drugstore and picking it up and actually taking it. And particularly in the United States, we have these auto refill programs. And it's becoming harder because, my electronic health record can tell me what they fill. But so what I'll kind of in clinic innocently ask, do you need a refill on your prevention inhaler? And I'll call it by name. And the honest ones will use, oh, I've got a stack of those at the house, but what I really need is my rescue inhaler, which has given me the information that I'm looking for. But we need a better solution, all right? We need one that supports patients in the real world and helps them stay on track so they don't have a stack of these at the house, and makes adherence achievable and scalable. And we have one now. So moving to the next slide. So I'm excited to share new evidence that shows a better system is not just possible, it's here. It's ready to deploy and scale across clinical settings in the United States and around the world. So we're going to look at early results from the iCARE study conducted at Intermountain Health. And I know not everyone here is in the United States, but it's really one of the most respected health systems in the United States, and it's where Adherium's technology has played a pivotal role. And these results are just the beginning. It's just the tip of the iceberg. And what we're seeing now is just a first glimpse at a larger story. And the data is just so rich, and even more impactful outcomes are still coming. And Adherium is justifiably anticipating many presentations, abstracts, and papers in the years to come. And I'm hoping that me as a socioeconomic expert, I can maybe be a part of that. So just to be clear, I'm speaking as an independent clinician. I don't have any affiliation with Intermountain Health, but I can tell you these results are remarkable. And our patients deserve far better respiratory care than they've gotten historically, and Adherium's delivering that. So moving to the next slide. So before we get into the results, let's talk about Intermountain Health, because understanding who they are, understanding just how significant this data is. So Intermountain Health is one of the most respected healthcare systems in the United States. They operate 33 hospitals, 385 clinics across 6 states. Their biggest state's Utah, but they're also in Idaho, Colorado, Nevada, Kansas, and Montana. And they serve patients across the spectrum in urban centers, suburban areas, in rural communities. And Intermountain manages more than 250,000 respiratory patients. So asthma and COPD isn't part of what they do. It's a core strategic focus, and an area where they've set national benchmarks for outcomes. And so they're also widely recognized as a leader in respiratory care. So they have a health plan. It's called Select Health, which insures more than 1.1 million members. And so through that, they can directly link the improvements in clinical outcomes to measurable cost savings, and it creates a powerful feedback loop between care and cost. And so this integrated model is exactly why iCARE runs as part of routine clinical care rather than some paid research study. It generates real world data on performance and outcomes at scale. And again, importantly, I'm repeating myself a little bit, but this isn't a controlled clinical trial. The patients were enrolled entirely at the discretion of their physicians with no incentives shaping participation. No one was handpicked for optimized outcomes. The physicians simply offered the program to any patient they thought would benefit. And neither the patients nor the clinicians were paid to take part of it. So this means the results you'll see today reflect authentic everyday clinical practice, not idealized clinical trial conditions, but the reality of how care is delivered and how patients respond in the real world. So moving to the next slide. So Intermountain Health partnered with Adherium to power up iCare, and it's designed to improve patient outcomes by embedding digital respiratory management directly into everyday care. iCare uses Adherium's Hailie Smartinhalers as the primary data source, providing objective, continuous views of how patients use their medicines and their inhalers. And this shifts adherence from guesswork to measurable, actionable data. And so I think of iCare as kind of an end-to-end ecosystem built entirely around the patient. So smart devices capture real-time data on medication use and inhaler technique. A cloud-based platform analyzes that data and provides actionable insights to the care team. Automated behavioral nudges support daily adherence and proper inhaler technique. And when the system detects, troublesome patterns like not using your controller or using your rescue inhaler too much or not inhaling properly or poor inspiratory flow, then it automatically triggers an escalation to a respiratory therapist for targeted intervention before the situation worsens. So moving to the next slide. So Adherium launched iCare not as a pilot, but as a real-world clinical program fully embedded into routine care and deployed at scale. The cohort we're looking at now has 848 patients and counting, and many of whom have been followed more than 14 months. And for context, most of the previous studies in this field have tracked fewer than 50 patients and usually for 6 months or less. And so I'm reminded of a journal club at the university I'm at, UAB, and again, I'm part-time, and they were having a journal club, and one of my colleagues sent me a text, hey, do you want to join journal club? I think maybe the attendance was low that day. And so I piped in, and lo and behold, it was a meta-analysis on Smartinhalers. And so we were going through these, and the sample sizes were tiny, and they weren't getting significant results just because the companies that were performing the studies were just hopelessly underfunded. And so this really speaks to the scale and the duration of what Adherium is looking at, because it's really unheard of. And it was a huge investment, and it was potentially risky because most big clinical trials, if you're any good, you can look at the clinical design and say, oh, well, this is what the outcome is going to be. But because there wasn't any coaching about how we were going to select patients, just they were the doctors in Intermountain Health picked whoever they want. And I can tell you, if I was one of those doctors, I'd have been picking my bad patients. I mean, those are the ones that I want to see get better, the ones that were really bad. So this just was a huge investment for him. So again, patient selection was driven just by the physicians. So Intermountain clinicians offered the program to anybody who was over 18. It wasn't a pre-screened or an optimized group. And just for reference, and this is something that I often say in talks that I give, but about most studies just aren't real world. The people in the studies are paid to take the drug. They're kicked out if they don't take the drug, and they're screened at entrance to be able to use an inhaler properly. And this isn't anything that's, dastardly. The FDA requires all of this, but these aren't the patients in my clinic. And On top of that, there's specific selection criteria that picks patients that are likely to respond. So this was a fully independent health system initiative. No vendor paid monitoring, no incentives for the patients, no payments for the clinicians. The program was designed, implemented, and run entirely by Intermountain Health's own care team and fully integrated into their existing clinical workflows. And so this means it wasn't something layered on top of their care, it was the care. And so this combination of scale, duration, independence, and clinical ownership is exactly why the outcomes are so compelling and reflect true everyday clinical practice, not an artificial research setting. And that's what makes the results so credible, repeatable, and scalable. So moving to the next slide. So what we've all been waiting on. All right. So we'll move away from how it was designed into what it really achieved. And so these are the initial results that just show how powerful this approach is when driven by Adherium's Hailie Smartinhaler technician. So in typical real world care, adherence is shockingly low. Looking at the studies, often between 20% and 40%, but most of them closer to 20%. But again, these studies measured the adherence by refills. And it's misleading because of the auto refill programs. And so they're probably artificially inflated, but with the Adherium numbers, this is measured by actual use. So even with those limitations, with iCARE, the adherence climbed to about 67% in COPD and 64% in asthma. And even if we take the most conservative measure, that's 1.5 times higher than the standard of care, but really probably closer to 3 times higher than the standard of care. And this isn't just an incremental improvement. It's solving one of the most stubborn, costly, and difficult problems in respiratory care, and it's doing it at a meaningful scale. So we'll move to the next slide. So as we talked about earlier, about 60% adherence is the critical tipping point in COPD. And once a patient reaches that level, the risk of hospitalization drops in half, and concurrently, the cost risk goes down. So in iCARE, the average patient suppressed that threshold, meaning that they were already in the range linked to significantly lower hospital use and cost. Even more compelling, nearly a third of the patients achieved adherence rates of 80 to 100%, far exceeding what's typically seen in a real world care. So the patients with continuous monitoring and feedback finally hit adherence levels that translate directly into fewer hospital visits, lower costs, less lung damage. Next slide. So unlike a lot of adherence or compliance programs that spike up early and fade, iCARE demonstrates sustained adherence well beyond a year, proving that this is a lasting behavior change, not just a temporary fix. So in typical asthma adherence studies, it typically drops to about 28% after 6 months. And in iCARE, it remained at 64% after 14 months, more than double the standard of care and over a longer period of time. And in COPD, the difference was even greater, where most studies show around about a 22% adherence 12 months after the intervention. In iCARE, the patients maintained 67% after 14 months. And what's particularly striking is that this level of persistence is seen even in patients in their 70s and 80s. And it's a group that's often assumed to struggle with technology. And this group really has the highest risk of flares and hospitalizations and costly complications. So not only did older patients embrace the Hailie platform, they remained consistently engaged, demonstrating that the solution was intuitive, scalable, and effective even in this population. And, and that matters because sustained adherence is what ultimately drives fewer exacerbations, fewer emergency department visits, fewer admissions, and creating a durable clinical and economic impact over time. If you would move to the next slide for me. So I'm here because I've seen firsthand how this technology can be transformative in patient care. Others in this space have failed because it created added burden on the physician and not relieved burden. And in my heart, this is just a technology that can't go away. And I'll show my age. I recall an early interest into this space in the 1990s. A device called an AirWatch, which was doing remote physiologic monitoring. And the reams of data came to my office on thermal fax paper. All right, that's how long ago it was. But then I've also worked with the Teva Smartinhaler device, and it created reams of electronic data. And we still didn't know what to do with it. So Adherium has finally developed a care system that doesn't add to the work of the physician, but actually assists the physician in providing cutting edge care and a modest revenue stream. We need this. Adherium has finally found a solution where the others have failed. And the pattern is clear and compelling. Adherium's technology consistently lifts adherence above routine care, measured objectively in real-world clinical workflows. And because of that improvement, a significant proportion of patients cross that important 60% threshold, the point where hospitalization risk begins to meaningfully decline. And it's not temporary. Adherium-powered programs sustain high adherence beyond 14 months, translating behavior change into long-term clinical impact. Fewer flares, fewer emergency department visits, fewer hospitalizations, and lower cost. And the impact is powerful in older, high-risk patients as well. And preventing even one flare can break the cycle of cardiopulmonary decline and avoid that catastrophic cascade of costly hospitalizations. And in the decades I've been in respiratory practice, I've seen no other solution that delivers sustained at-scale results like this. And none of it would have happened without Adherium's Hailie platform at the core. So simply put, Adherium keeps patients on therapy. And when patients stay on therapy, flare-ups drop, hospitalizations drop, cost savings come in. And from my perspective as a clinician, Adherium isn't just improving outcome, it's redefining what's possible in respiratory care. And without it, programs like iCARE wouldn't exist. So I appreciate the time to be able to present this. I'm going to let Kevin walk us through what these results will mean for healthcare plans and system-wide cost.
Thank you, Dr. Meadows, and thank you everybody for attending the webinar. My name is Keven Gessner. I have a background of about 25 years in pharmaceuticals. I've worked for most of the large respiratory pharmaceutical companies, including GlaxoSmithKline, Pfizer, Teva, and AstraZeneca. So I'm just going to talk a little bit about what this could mean for payers, because ultimately in the United States, the U.S. government and private insurers pay for the huge cost of COPD and for all the cost for severe asthma as well. So I'm just going to jump to the next slide, kind of walk you through a quick model of what this could mean for Intermountain's payer, but also Cigna Health. I had the pleasure of having dinner this week with senior vice presidents at Cigna as well as Evernorth. And we were discussing a bit about the cost of COPD and chronic care. Chronic care is crushing payers and the government in the United States, but not just the United States, but around the world. So really quickly here, if we were to just simply take Intermountain has about 1 million payer lives under its payers. So that would translate at about a 5% participation rate of their COPD patients would be about 3.3 thousand patients, and a 50% reduction in their hospitalization and ED visit costs would equate to about $30 million in savings to Intermountain's health plan. For remote patient monitoring for diabetes, a lot of the payers are paying between $70 and $100 per patient per month. So conservatively, we just modeled out $70 per month. So if we were to put 5% of the Intermountain Select Health patients on this, it could generate around $3 million in revenue for Adherium. At a 10% participation rate just for COPD, about $6 million for Adherium, and about $60 million in savings for Intermountain Select Health. Now, Select Health has, like I said, about 1 million patients. So I'm just going to quickly model out what it would mean to Cigna Health, which are some of the folks I had dinner with this week. So Cigna has about 20 million medical lives that they currently cover in the United States, based on the background rate of COPD. If 5% of their patients, about 53,000 patients with COPD participated in the program, and they experienced a 50% reduction in hospitalization and ED costs, it would equate to nearly $500 million in savings for Cigna. For Adherium, at a $70 per patient per month, would be about $44 million in revenue. At a 10% participation rate, you can see the numbers right under there, about 100,000 patients, about $1 billion in potential avoided cost, and about $88 million in savings, in revenue for Adherium. So the way these payers have been utilizing remote patient monitoring and continuous care in diabetes is they find organizations that can provide the services, and they hand them a list of all their high-cost patients. They know who they are because they pay the bills, and they get those organizations to enroll those patients. There is no program for COPD that's out there like Adherium's. They do not have anyone else to really turn to. So there's lots of continuous care and RPM companies in diabetes and even cardiovascular disease, but nothing of its kind in COPD. And that was part of our conversation this week with Cigna. They are looking for solutions to bring down their cost in COPD because it's the fourth leading cause of death worldwide, and cost them billions of dollars. So I think this can give you a little bit of a flavor of the potential savings for payers. So they're highly motivated to find programs that are effective at bringing down specifically hospitalization costs and emergency department visits in this space. And you can see even at a modest cost of $70 per patient per month, the return on investment can be huge. Cigna was an early adopter of other programs like Omada Health, who currently focus in diabetes, continuous care, and also in cardiovascular disease. But those companies, again, do not have any COPD or respiratory solutions. They don't offer them, and they don't have them, and they've never built them. And part of that is because they don't have Adherium technology that generates the important data that actually tells people who's getting sick and who needs the intervention to keep them out of the hospital. And none of that technology that they have actually helps the patients take their medication. And as Dr. Meadows pointed out, if we can get these patients to compliantly take their medications, we reduce the risk of hospitalizations by half. And that's what makes our technology unique and very intriguing to the payers. So I only have one more slide. I'm just going to do a quick little summary. You know, the point of this program was to run something in the real world that with an organization that was reputable, but also has a payer so we can measure the outcomes and see the results as well. Adherium has the broadest portfolio of FDA-cleared devices. We now have real-world evidence at scale. To Dr. Meadows' point, this is nearly 900 patients. This is the largest continuous care remote monitoring and respiratory program by far. We have coverage for almost every patient with severe and moderate COPD with our devices, with our FDA-approved devices, and also with asthma. They're the same medications used in asthma and COPD. So we have tremendous coverage for the patient population. And we have the ability now not only to track and improve adherence, but also track and improve technique. And from this study, we'll continue to gather additional data that's going to be really impactful to payers and patients. So I think I'm going to pause there, Dawn. I think we're going to switch over to any questions. Just a quick update on how we're doing with onboarding. So as some of you may know, we implemented outbound call centers. We have, in the last 6 months, onboarded over 700 patients. So we effectively went from 0 to 750 patients in the last 6 months. With our non-Intermountain program, we have 850 patients on an Intermountain. So you can see 1,500 patients now on board in clinical care settings in a relatively short period. I think we onboarded well over 100 patients just last week. So the onboarding pace is scaling up quickly, and we're looking to continue to invest in onboarding teams. We have a large backlog of patients, about 70,000 patients on a waiting list, waiting to be contacted by us that we have access through Allergy Partners and other physicians to start enrolling into the program. So I'm going to pause there and pass it back to Dawn, and I think then we're going to take some questions. Dawn, you want to do the final key takeaways?
Yes, absolutely. So I think as you've all heard between Kevin and Dr. Meadows, the iCARE program really is, again, a real world demonstration of substantial data insights where Adherium technology, specifically the Hailie technology, does improve adherence. That adherence is, of course, directly tied to the reductions of hospitalizations, the reductions of emergency department visits, and of course, those have a direct impact to reduction of overall healthcare costs. As Kevin had demonstrated, those reductions in costs can save payers. He gave the example, of course, of a smaller payer like Select Health, but a large payer like a Cigna, substantial amounts of money to the tune of billions of dollars. And of course, we now have the technology and the proof, and we're demonstrating the ability to scale with the US providers and payers. So with that, this does conclude the presentation portion of our webinar, and we will now address questions uploaded into the chat.
Okay.
So the first question that we have from the chat is, what does it take for a group like Cigna to engage with Adherium for their COPD patients? So Kevin, if you could take that question for us.
Yeah, absolutely. It's a question that I asked Cigna literally this week. And the first thing they wanted was the data. Show me that you can improve adherence, show me you can improve in technique, and then reduce hospitalization. So that the first thing they're looking for is what we're generating out of Intermountain through a reputable real-world study. And as Dr. Meadows talked about, this is a large, reputable real-world study done by one of the leading institutions in the world, completely independent. So that was step one. The second thing is they want to see scaling. Can you put large volumes of patients? Because what Cigna told us they would do is, if we had an agreement, they would say, here's 100,000 names, telephone numbers, addresses, and emails, and cell phone numbers for you to contact the 100,000 COPD patients that are costing us the most money. Can you use that to enroll patients and get them on? Because if we can't get them on and participating in the program, then they don't save anything and the patients don't get better. We are now proving, we built our call center out and we launched our call center, and we are now proving that we can onboard patients through the call center and through our digital onboarding processes, email campaigns, text campaigns, and our call center. So that was the second thing they want. And the third thing they want is strong service levels. Obviously, they're looking for an organization that is going to be around and servicing their patients for a long time, because COPD isn't going anywhere. The COPD cases continue to rise in the United States and around the world, as well as severe asthma. And they're looking for an organization that has extremely strong service levels to service an organization with 20 million patients, such as Cigna.
Wonderful. Thank you, Kevin. A second question that we had come in is that we understand the health economic benefits of the Hailie and patient adherence. Please provide more detail around why this time is different for patients' willingness or ability to adhere to the Hailie technology. And what has Adherium learned from previous companies that have not been able to get patients to adhere in this space? Dr. Meadows, you made mention that you've had experience with previous companies. If you could take the first pass at an answer to this question, and then Kevin, you can feather in any additional context as well.
There wasn't an ecosystem built around the previous ones in the United States. I was a big adapter of the Teva system, and it was delivering just such great patient outcomes that I'm different. I didn't care so much that it cost me time. But the old saying goes, time is money, and it generated this data, and with the data that it generated, if I wasn't looking at it, there was kind of a medical legal responsibility for me to respond to something. And it was something that my staff was already overworked. And so, I just get in 30 minutes earlier and look at it. And I mean, it delivered outcomes, but most physicians weren't like that. And I think, like the example I gave during the talk, it just was generating so much data and was creating such a burden for physicians that most of the physicians signed up 1 or 2 patients and saw this. They said, this is for the birds. And so, it wasn't that the patients didn't like it, and it wasn't even that it didn't deliver good adherence outcome. It did deliver good adherence outcome. It was just too burdensome for the physician to use.
Yeah, Dr. Meadows, I'll elaborate a little bit there because I was the vice president of respiratory at the time when you were one of our top users of the Digihaler. But Dr. Meadows is exactly right, and that's why I've continued down this journey. Though there were 2 challenges with Teva. One, you had to switch to Teva's drugs, and a lot of people didn't want to switch their medication. Dr. Meadows would switch people to the drug, but a lot of physicians would not do that. We do not have that problem at Adherium because we have add-on jacket devices for almost every COPD medication out there. So if somebody's on a drug and it's well covered and it by their payer, they don't have to switch that. So that's one huge reason that this technology will work. The other thing that Dr. Meadows hit on is really important. The Teva system generated phenomenal data like inspiratory flow similar to ours. But it threw that data over to a very busy physician like Dr. Meadows and said, hey, you take the data, you look at it, and you figure out what to do with it. And Dr. Meadows is an anomaly because he cares about his patients probably more than any I've ever seen, but he would actually do that and do it free. Most physicians don't have the time or the willingness to do that because they have to see 20 patients a day, right, Dr. Meadows? The other thing is a lot of the physicians really didn't know what to do with the data because it was overwhelming. And with the Adherium platform running at Intermountain, we actually have an AI model that interprets what the data means. So this allows the technology to actually ingest all the data, whether it's utilization data, rescue medication data, inspiratory flow data, technique data, and say, okay, now I can look at this data. The system looks at the data, does 95% of the analytics, and then says, okay, here's the one patient Dr. Meadows needs to look at. So it may be monitoring 1,000 patients.
Kevin, is they have codes now. And so back in some of the earlier models, there weren't codes in the United States to be able to file for this. And an increasing number of insurance companies, including not only Medicare, is paying for this. And so there's actually a mechanism. There's a way to appeal to get an insurance company to pay for it. I'm sorry I interrupted you.
No, it's perfect because it was leading right where I was going, Dr. Meadows. The other thing is now not only does the system interpret the data, but we have put care teams in place at Adherium that work as a business associate to a physician like Dr. Meadows. So when an alert comes out, it comes to a care specialist, either within the practice or within our teams if they want us to monitor the data. And then we work as an associate to the physician, and all that time and effort and results are billable. So then that information is then billed to the payer, and not only does Dr. Meadows not have to look at it for free, we can have a respiratory therapist at a lower cost monitor the data, determine what to do, submit reimbursement to the payers, get paid. Dr. Meadows then sees the patients that he needs to see after they're triaged by a respiratory, well, first by the AI and second by the respiratory therapist. Dr. Meadows would then see the types of patients that actually require a physician's care, and the respiratory therapist would manage the patients that can be managed by a respiratory therapist. So it allows us to deliver much more effective care at a much lower cost than in the past. And physicians like Dr. Meadows don't have to do it for free. They can actually get paid for their important services, and the patients get better. So that it's really a complete win-win-win, and the payers save money. So
that was always the most important thing for me, Kevin. The patients got better.
Correct. So the patients get better, the payers save money, the physicians get appropriately compensated for their time, and Adherium gets compensated for its.
Kevin, Dr. Meadows, thank you for providing such comprehensive answers to that specific question. The next question that's come in, Dr. Meadows, you're probably the best to answer this, is that the adherence numbers look good. What is the baseline expectation prior to the study commencing? We've noticed that you're using previous study data as the baseline, and this is between 20 to 40%. Did Intermountain have their own baseline?
Well, because this was a real world study and not a controlled study, if this was a controlled study, we would have looked at the patients for an index period, weeks or months beforehand and had a baseline adherence. But if we were asking Intermountain Health to do that, then that would be a significant amount of work, and Adherium would have to pay them for that. And so, because it's a real world study, and because that's not data that was collected up front, it would be a burden on Intermountain Health, and they may not have wanted to launch this program if we had asked them to do that. But yeah, that's why. But I would suppose I would imagine it might be lower than the 20 or 40%. We're not coaching them who to pick. And again, I'm not part of Intermountain Health at all. But if it were in my clinic, we would be picking the most non-adherent patients to enroll in this program because that's where I need the most help.
Yeah, and Dr. Meadows, I think you referred to the data that we used as the baseline. Most of that, there has been lots of work to look at adherence on inhalers because it's been a common problem. That data is prescription data. So one way to look at adherence is, do you fill your scripts? So when I was at AstraZeneca leading their inhaler business, we saw an average of about 3.7 scripts out of every 12 months. They should have been filling 12. They were filling 3.7. And I think, Dr. Meadows, you brought this up really well. You may have filled 3.7, but you probably only took half of that. So your adherence is sub 20% in many cases with what they actually took. So that 20 to 40% that was cited, again, was prescription data.
And Kevin, beyond that, I'm bragging again. My adherence was the highest in Alabama, but some of the pharmaceutical companies that brought biologics, they thought because my high numbers, I should be a big biologic prescriber. Well, I wasn't, because my patients were taking their medicine. Like we said, the 50% was enough for a lot of these patients, and they weren't getting sick. So it makes a difference.
Yeah, no doubt. And we know most of those patients would not need to pay for a $60,000 biologic had they taken their inhalers adherently.
Yes, again, another very solid answer. Another question that has come in: have and how many they need to service 25 to 30,000 patients. And I think, Kevin, this speaks to a lot of the value-based opportunity that we've got in front of us. So if you can answer this question.
Sorry, Dawn, there was a little bit of interference right as you were asking me the question. Do you mind just repeating it?
I can repeat it. So how many employees does Adherium currently have, and how many do they need to service 25 to 30,000 patients?
Okay, yeah. So we have somewhere around 45 employees today across software development and commercial and business development. I think the more relevant question, at least the way I think about it, is how many people does it take to service each patient we onboard? So today, a respiratory therapist is monitoring about 300 patients. With the Intermountain structure, though, we believe one respiratory therapist, which costs about $65,000 a year, will be able to monitor over 1,200 patients, primarily because the vast majority of the work in a value-based health system model, like we're doing with Intermountain, will be done by the AI and the tech. And then any alerts where a patient is having a problem will be received by a respiratory therapist, where they will then engage the patient on an as-needed basis. So effectively, the data from the Adherium Hailie devices tell the respiratory therapist who needs to be looked at and who does not. So if a patient is using their medications compliantly, their inspiratory flow looks good, and there's no reason then for a human to intervene. So with the addition of the platform and AI model, we can go up from 300 patients per respiratory therapist to well over 1,200. That completely transforms our cost model. Additionally, with value-based programs with payers, they are not fee-for-service models where you get paid based on the time looking at the data. Cigna will not care if you spend 5 minutes or 1 minute looking at the data. What they care about is, can you save them money? And that's what this platform is showing them, that we can save them money if we reduce hospitalizations. They will pay us for that. And that's the key. We're really leveraging AI and tech to monitor the data and tell us who needs to be looked at by a human, who's doing well without being looked at by a human. And Dr. Meadows, you can speak to this. It's really difficult for you to know, of all your thousands of patients, which one of them you need to help today. And they don't call you. They never do. They wait until they're in the hospital, and that's when you see them. So maybe you can opine a little bit about just the behavior of patients, and what this technology allows us to do is see who is about to need help, and alerts us to that before the patient will ever say anything.
Right. With the old Teva dashboard, if the traffic was bad and I was running late, I didn't look at the dashboard for a few days, then it was on me. I miss these people. There was no automatic alert that came my way. And even if you've got an in-house respiratory therapist to do it, having this whole system in place to be able to do it, and then we get the automated nudges. We get the respiratory therapist, and then the very top of the pyramid are the ones that we would really need to address inside the office. And again, the way the codes are set up for that, the more time that we have to spend on them, we actually get paid better for it. So it's a win-win.
Yeah, that's right. The early dashboards required everyone to look through each patient manually and try and pick out which one needed help. And now with the invention of AI and data analytics, we can interpret the data, figure out who needs help, and then send an alert just for the patients that need help, which will dramatically allow us to serve a lot more patients with fewer staff. Hopefully that answered the question, Dawn.
Yeah, no, thank you for that, Kevin. Another question that's come in is, as an Australian company, how do recently implemented tariffs affect rolling this out at scale in the United States?
Yeah, I don't mind addressing that one too, Dawn, if you want. So the cost of goods on our devices are relatively low. So even if we had to pay a tariff on a $25 device imported, it's going to be minor. Our revenue is primarily driven by the remote patient monitoring, and it's done in the United States. So there's no tariffs on the work. Our staff are here in the United States, recruiting the patients, monitoring the patients, and the cost of the device is relatively low.
Thank you, Kevin, for that. So we've got about 7 minutes left in the overall presentation and the Q&A session. So we've got probably time for maybe about one more question or so and a very thorough answer. So from a commercial standpoint, how do you intend to reach scale? And what are the actual patient signups that have been projected over the next 6 to 12 months?
Dawn, did you want to take that one, or did you want me to take that one?
Kevin, if you could maybe speak to the scale piece, and then I can talk about the patients that we anticipate over the next 6 to 12 months.
Yeah, I mean, we recently launched call centers, a call center with 5 staff outbound, doing outbound recruitment. Like we said, we have about 70,000 patients that Allergy Partners and Sensa handed to us to start recruiting. Obviously, they want all these patients on. One, it'll make, to Dr. Meadows' point, these patients will get better. And two, it creates a new revenue stream as well for them. So we're currently onboarding patients every day. And what I can tell you is every week's been larger than the last week. Over the last, since we've launched the call center, I think we had, with the 5 outbound callers starting just a few months ago, I think we had 29 patients onboarded. I think it was either yesterday, Dawn. Probably when we first entered the program with Allergy Partners, it took us 6 months just to get the first 17 patients. Now we're doing 30 a day. If I were to look back, probably about 2 months ago, Dawn, we might have been doing 30 or 40 a week. So we're picking up the pace and picking up the pace quickly. Certainly what we'd like to do with resources that we get is to bring some additional call center folks on board so that we can actually increase the pace even faster. So really, our pace of onboarding is limited by resources. So we have the patients, we have the contracts in place, we have the monitoring staff, we need the resources to onboard them. So the faster we can get more onboarding resources on, the faster we can scale. And I'll let you talk about long-term projections, Dawn, if you're going to do that.
Yes. So really for the next, for the next 6 months, again, as Kevin had said, that is also very dependent on the resources. Really by the end of the year, as you saw on the previous slide, we're targeting around 4,500 patients combined between kind of all mechanisms, including the Allergy Partners piece, the Intermountain Health piece, and some of our other hospital payer opportunities. So again, we continue to just demonstrate day over day, week over week, and month over month growth. And we anticipate that continuing to go with a break-even point where we anticipate around at around 25 or so thousand patients sometime about midpoint next year. So Dr. Meadows, if I can put this back to you and essentially pose a question to you on just your sense of the impact of this technology. You've seen it for a long period of time. You've been a part of this, and the overall opportunity that Adherium has to really take this and close this out for us today on our presentation.
Well, I'll give you an example of a patient that I use the Teva product on, and again, it's the same basic technology that we're using, except, well, the hearing device, we got an on-device warning. That's even better. The device beeps, whereas nobody else's product did that. It was more a reminder in your smartphone. But a close friend of mine, his daughter was a patient and just really not doing well, and she's an adult daughter, one of these millennials that are living on their cell phone, and just had her on the highest level of asthma care and was considering putting her on a biologic. And this was about the time the Teva Smart products were launching in the United States, and so I switched her to that, and it was actually represented at least a 50% cut in the amount of medicine that I was supposedly prescribing for. And again, she was filling these, but I didn't know if she was taking them. Well, I looked at the app, and this young lady was using her inhaler every day. She went 3 entire months without missing a single dose, and voila, she was well. She was never sick. She didn't need to use a biologic, and and I was kind of feeling bad because this is my good friend. I'm failing treating this daughter. I'm the allergy specialist. I'm supposed to be doing this, but just wasn't able to convince her to take the medicine until her phone convinced her to take the medicine. So, that's why I'm a believer. I mean, I've seen this work, and I don't want to see this opportunity go away in the United States. I think it has the potential to revolutionize asthma and COPD care. And this patient had asthma, but asthma and COPD care in the United States. So. I don't know if that was what you were looking for, but it's I believe in the technology. I think it's unfortunate that some of the competitors have gone away, but I'm very hopeful and optimistic about Adherium.
Wonderful. Well, first of all, I want to thank Dr. Meadows for you to take time today to walk us through the results of the iCARE study, put it into perspective on how it compares to benchmarks that are currently in the literature, and of course, in your practice, in your practical experience. And Kevin, again, your insights into the opportunity from a payer standpoint, and of course, how Adherium is continuing to work through this immense amount of patient backlog that we have had. So thank you everyone for your time and thoughtful attention. If you have further questions that weren't addressed on the call today, of course, please feel free to email them to us and we'll provide additional answers. And just in closing, this is Adherium and the time is now. Thank you for all your participation.